All right, welcome everybody. It is August 8th. It's Friday. This is the Florida EMS webinar. This is a function of the Florida chapter of the NEMSP. For myself, Tanner Smeda, Dr. Paul Pepe, we invite everyone every week to have a great discussion about a very interesting topic. And this week is going to be another great one. We have Dr. Chris Naas from Hennepin. He's a PGY1. He's a researcher. He's a firefighter EMT. He's done it all at his young age, and he just published a great paper in Resuscitation. He's the lead author. We also have senior author and friend of the pod, Dr. Tom Ofterheide. So welcome, Dr. Ofterheide, as well. And Chris, if you want to take it away, make any further introductions, and thanks for joining us today.
Yeah, good morning, everybody. Thank you so much for having me. I'm really honored to be here, and I'm fortunate, too, that two of my big mentors that have really helped me get to this point are both here as well, Dr. Tom Ofterheide and Dr. Ben Weston, who are both authors on this paper. I just recently moved up to Minneapolis from Milwaukee. I was in Milwaukee for 5 years to do my MD and my master's in public health, with a big interest in cardiac arrest, particularly. So moving up to HCMC for training now, I'm really interested to continue that line of research in a new system as well. So today I'll be talking with you about a paper that we worked on during my time in Milwaukee, looking at associations with the resolution of STEMI criteria on serial 12 leads following out-of-hospital cardiac arrest. I have no disclosures to report. So just some foundational background information. We know that there are high rates of coronary occlusion found in patients who are resuscitated from cardiac arrest across a number of studies, and that ST elevation on post-ROSC 12 leads is associated with a higher incidence of that occlusion. American Heart Association guidelines currently recommend emergent angiography for patients resuscitated from cardiac arrest with ST elevation on their 12 leads, which has a high level of evidence to support it. As indicated here in their AHA guidelines. And their specific verbiage is this should be obtained as soon as feasible after ROSC to determine whether acute ST elevation is present. That said, changes on EKGs are dynamic. We know this looking at STEMI broadly. There's been research in this area that shows that single EKGs do not necessarily stay the same over the course of a patient's clinical care, both in the pre-hospital and the emergency department settings. And particularly after cardiac arrest, we know that the EKG can sometimes be unreliable, and this varies with the timing of that EKG acquisition. This study done in Europe found a higher rate of false positive STEMI on EKGs when those 12 leads were obtained within 7 minutes of ROSC compared to at a greater time than 7 minutes after resuscitation. So some of this information informed an initial study that was done by Dr. Ofterheide and others at MCW slightly before my time, where they looked at 176 patients who were resuscitated from cardiac arrest, and they were looking at dynamic changes in 12 leads over the time from the EMS care to the emergency department encounters for those same patients. And they noted that roughly 50% of patients had some change in the ischemic classification of their EKGs between the out-of-hospital and emergency department settings. The table here in the bottom right corner goes into a lot of the nuance of those different types of breakdowns, but most notably in this initial study, 67% of patients with a STEMI on their out-of-hospital 12 lead after ROSC showed resolution of that STEMI when they were evaluated in the emergency department. So these are some very large numbers that definitely piqued a lot of curiosity. So the fundamental question here is why is it that 2 out of 3 resuscitated cardiac arrest patients with an initial STEMI no longer have that STEMI when we do a repeat EKG in the 12 lead? And what does this mean for our decisions to mobilize the cath lab and to really inform the patient's post-resuscitation care when they get to the hospital? What does the role of EMS 12 leads really have in this context? So that was ultimately what informed our subsequent paper. These are all of my co-authors here listed that informed our next project that we'll talk about. So the primary purpose of our subsequent study was to really identify any associations with this high rate of MS STEMI on repeat emergency department EKGs following resuscitation from cardiac arrest. The STEMIs were really our main focus, but secondarily, we also wanted to see if there were any associations we could identify related to any changes in ischemic classification of out-of-hospital non-STEMI EKGs. So to do this, we used the same retrospective case series in the initial paper that was published. We looked at adult non-traumatic out-of-hospital cardiac arrests who were resuscitated by EMS and transported to the single tertiary care hospital in Milwaukee, Wisconsin. All of these patients in our study had to have a minimum of one EMS and one emergency department 12-lead EKG in order to make a comparison. If there were multiple EKGs acquired in either of those contexts, we used the most ischemic EMS EKG and we compared it against the last emergency department EKG, as we felt that these would be the two EKGs that had the greatest weight when making clinical decisions in either context. Certainly, EMS crews may use that most ischemic EKG to activate the cath lab in the pre-hospital space, and the most recent EKG in the emergency department would be most likely to inform disposition to the ICU or the cath lab for those patients. So all of the EKGs in this study were reviewed by 2 emergency physicians and 1 cardiologist, and they together reached a final consensus classification for EKG, each EKG in the study, and those classifications were either STEMI, based on the AHA STEMI criteria at the time, the 2017 edition, the ischemic classifications where there were ST or T-wave abnormalities that did not meet STEMI criteria, or non-ischemic without any such abnormalities. These 3 reviewers achieved an inter-rater reliability with a kappa score of 0.63, indicating substantial inter-rater reliability. Our primary interest in this study, as I mentioned, was looking at associations with resolution of a pre-hospital STEMI on subsequent emergency department EKGs. But we also looked at associations for non-STEMI out-of-hospital classifications as well. Our main parameters of interest in the study were patient demographics and cardiac arrest characteristics, the administration of inotropy or vasopressor medications, defibrillations, as well as time parameters pertaining to the resuscitation and the timing of EKGs. Those time parameters include the duration of the resuscitation, the time from ROSC to EMS EKG acquisition, and the time interval between our EMS and ED EKGs. So here's a flow diagram of the patients we had in our study. There were 176 adult non-traumatic arrests, which occurred between July of 2012 and July of 2019 in the Milwaukee County EMS system, which is a fire-based ALS system comprised of 14 different fire departments. These patients were all transported to Froedtert Hospital, which is the academic site affiliated with the Medical College of Wisconsin. So out of 176 patients, 49 of those patients had a STEMI on their out-of-hospital EKG, which was used. Of those 49, 33 had resolution of that STEMI on their emergency department EKG, while 16 had a sustained STEMI. You can also see the breakdown for the ischemic and non-ischemic out-of-hospital classifications. Of the STEMI patients, the median age was 62, and they were 71% male. Here is a graph which shows in gray the out-of-hospital ischemic classifications and the breakdown of what proportion of each of those out-of-hospital classifications had a STEMI when they got to the emergency department. So 16 of 49 patients with a STEMI in the field had a STEMI in the emergency department. 3 of 61 patients with an initial ischemic EKG in the field had a STEMI, which evolved. And then 66 non-ischemic patients, only 2 of them evolved to a STEMI while they were in the emergency department. So the resolution of the out-of-hospital STEMIs is very marked. The evolution to STEMI for the people initially without a STEMI is fairly minimal in comparison. So we'll start by really breaking down this group right here, as that was our primary interest. So this is a big messy table. We'll start to break this down, but these were all the different parameters we looked at to compare between resolved and sustained STEMI. Ultimately, we looked at age, sex, arrest characteristics, including initial rhythm. There were no associations with resolution or sustainment of the STEMI when looking at any of those factors. We looked at initial rhythm and defibrillation. And for our STEMI patients, there was no association with resolution of STEMI when you look at initial rhythm and the amount of defibrillations received either in the pre-hospital or emergency department setting for those patients with ongoing resuscitation, as well as that cumulative dose of defibrillation did not appear to be associated with resolution of STEMI. We looked at medications next, and we found a lot more interesting data here. So we looked at the total dose in milligrams of epinephrine these patients received during their resuscitation, both in the pre-hospital and emergency department setting, as well as in total. And we found that in all of these instances, the patients with resolved STEMI received a smaller epinephrine dose compared to those who had sustained STEMI by about 1.5 milligrams difference for those with out-of-hospital resuscitation. And in the emergency department, there was also a difference as well, which was significant. Only a small proportion of patients received an epinephrine infusion as part of their post-ROSC care. We did not get a signal there looking at that infusion. However, when we looked at norepinephrine administration for our patients following ROSC, we did note that incidence of norepinephrine administration was higher in the patients with a sustained STEMI compared to those who had resolution of their STEMI on emergency department EKG. And similarly, we did not get a signal for dopamine, which was still being used in the system at the beginning of this study period. So notably, epinephrine bolusing and norepinephrine infusions were both associated with sustained STEMI on repeat ED EKGs. We also looked at a number of time intervals related to the cardiac arrest resuscitation. There was an increased number of rearrests in our patients with sustained STEMI, and that just crouched on statistical significance. So there's a signal there, but it just barely hit the 0.05. Additionally, we looked at a couple different time parameters here, and these are quite interesting, I think. So looking at the time from ROSC to acquisition of that initial out-of-hospital EKG, the patients with sustained STEMI actually had a longer period of time from that acquisition compared to those with resolved STEMI. So 5.5 minutes was the average time for people who had resolution of their STEMI on subsequent EKGs, while 8.5 minutes was that duration of time for those folks with a sustained STEMI. Interestingly, that trend of greater time is different for our other two intervals that we looked at, and we can talk about that more later. But the time from acquisition of your out-of-hospital EKG to your emergency department EKG was significantly longer for those with resolved STEMI. That interval was close to an hour for those with resolution of their STEMI, while it was about 23 minutes for those with a sustained STEMI. So that shorter period of time appears to be associated with persistence of that ST elevation MI criteria on your EKG. And with greater time, it appears to resolve. And then we also looked at the duration of resuscitation, which we defined as the CARES documentation of initial chest compressions until the acquisition of ROSC, as indicated in the PCR. And we found that a greater duration of resuscitation was also associated with a sustained STEMI in the emergency department with a difference of about 7 minutes. So going back to here, we will briefly touch on these groupings of patients who had non-STEMI classifications in the out-of-hospital setting as well. So this is a noisy forest plot here. We were basically looking at, here are ischemic patients. We wanted to see what was associated with either sustained ischemia or evolution to STEMI, which is going to the right, versus resolution of ischemia, which would be a signal going to the left. These are all the same parameters we looked at for our STEMI patients. The only things that we found statistical significance to have an increased likelihood of sustained ischemia or evolution to STEMI for our ischemic patients was defibrillations, and that signal you can see here. Otherwise, there were no associations with medication dosing or time parameters for these patients with ischemic EKGs. Similarly, for non-ischemic subjects, we again see that defibrillations in the out-of-hospital setting are associated with evolution to increased ischemia if you have an initial non-ischemic EKG, and also a very large signal for an initial shockable rhythm. These findings here are fairly consistent with the notion of an evolving myocardial infarction and underlying coronary occlusion in a trend which is very distinct from a lot of the findings we observed with our STEMI patients. So here are some key findings to summarize from what we've just gone over. EKGs acquired in the post-ROSC period are very likely to evolve over time, and a STEMI on that initial post-ROSC 12 lead has a high likelihood to resolve, especially if you have a prolonged resuscitation necessitating higher doses of pressors and inotropes, both during your resuscitation and for your post-ROSC care. And you find that with less time from ROSC to EKG acquisition, it is more likely that that initial ST elevation will probably resolve rather than persist. And with greater time between our comparison EKGs, the likelihood of STEMI resolution appears to increase. So the question is why? Why are these things happening? And we have speculated a number of physiologic mechanisms which may explain some of these findings, particularly pertaining to the resolution of STEMI over time following ROSC. One possibility is that you may experience spontaneous thrombolysis, which has been well described as a physiologic phenomenon after resuscitation. You may also see distal clot propagation with that thrombolysis, and thereby sort of seeing a relief of that focal ischemia on your EKG. Additionally, it is well described that there are significant metabolic derangements that occur during cardiac arrest, hypoxia, acidosis, significant shock, sort of that global type 2 MI picture. And this is worsened with lengthier resuscitation. Vasopressor medications can lead to coronary hypoperfusion from really clamping down on those arteries, and that may cause more myocardial ischemia. And certainly this would explain some of what we see with time. With greater time until your initial out-of-hospital EKG, you have more time for some of this metabolic derangement to improve. And then similarly, with those greater durations of time between your comparison EKGs, you can again allow for some more optimization of your acid-base status, of your perfusion, and post-ROSC care can really support that. And that really supports a lot of what we're experiencing with our data here. Coronary vasospasm is also possible, maybe from defibrillation. However, we really didn't see a signal for defibrillation among our STEMI patients. But similarly, we did for our pressors, the epidosing, the norepi administration after ROSC. There may be an element of vasoconstriction supporting that. And it's also possible that some of these patients may have had non-occlusive coronary artery disease, and then with the superimposed global hypoperfusion from an arrest, you may see some localized ischemic changes on the EKG and sort of normalize back to a non-ischemic EKG. So let's talk implications, because I think that's what a lot of people in EMS are really interested about. And this paper brings up some interesting questions. Certainly the timing of an EKG following ROSC is a large one. It is important that we need to get EKGs to really guide our care in the pre-hospital setting. But there are a lot of other things that need to happen for patient care in the immediate ROSC period. And perhaps we can delay the acquisition of that immediate 12 lead in favor of really making sure that we have optimized our patient care. Starting pressors, managing blood pressure derangements, making sure we have a secured airway, getting the patient ready for packaging to move to the ambulance to try and prevent a rearrest. And once we're in a spot where those things are good, maybe then is an okay time to get that 12 lead rather than the moment after we achieve ROSC, so that potentially we can allow for some optimization of that metabolic derangement from the arrest before trying to get that initial 12 lead EKG. But even aside from that, there is definitely a lot of value in getting serial 12 lead EKGs. It should really be encouraged to crews that we should be getting more frequent 12 lead snapshots throughout transport and packaging to really provide a better picture of what is going on with our electrophysiology, with potentially our myocardial ischemia during the course of our care following resuscitations. And this can thereby really help to guide in-hospital care as well. Emergency clinicians, interventionalists can then sort of see how things are progressing during a patient's post-resuscitation care. There is certainly a lot of value to having systems in place to allow for the hospital to view these things. If systems are able to digitally transmit their 12 leads to the hospital and have those readily viewable in the emergency department, or at least provide the paper copies of all these EKGs. The big question now is, what do we do about activating the cath lab? Because do these patients have occlusive myocardial infarctions necessitating PCI or not? From this study, we can't really conclude that. We had a small subset of patient data on angiography, but we weren't able to comment on the underlying coronary occlusion here. Ultimately, the question is, are we waking up interventionalists too frequently for patients that have ST changes initially and then that goes away? Are we angering our consultants by overactivating and calling wolf too much? It's hard to say, but I certainly don't want the takeaway from this paper to be that we activate the cath lab less for patients that we're concerned have a need for emergent PCI. Ultimately, I think that those decisions need to be made with the best available information we have, and really with the intent of most aggressively trying to reperfuse patients who need to go to the cath lab for an ischemic arrest. So certainly more work is needed in this space to really inform these things in the future. So some next steps that are really interesting and I'm excited to try and look at while I'm here at Hennepin potentially is there underlying coronary disease when these STEMI patients resolve? We really need angiography to the predictive value of 12 leads at different time points following ROSC, as well as looking at how medications and other aspects of resuscitation may inform that value of your 12 lead. Certainly doing this with a larger sample size, more than 176 patients would be valuable. And what I'm most interested in is how will these results change when looking at broader EKG diagnostic classification tools using more of the occlusive MI classification system, and as well as some of the emerging AI technologies to interpret EKGs. I think these are all very promising areas to continue to look at in the future. Thank you very much for your time and listening, and I'm happy to take any questions.
Wow, this is a great presentation, and I know it's going to bring up a lot of questions. One of the questions you just had up on that last slide, if you can go back one, Chris. I think for me, that top left slide was whether or not there is underlying coronary disease when the STEMI resolves, right? So knowing that would really be very helpful to everyone to understand whether or not the cath lab needs to be opened or not. Are there no current studies on that topic, or do we have any information on that?
So there's nothing looking at serial EKGs and angiography data that specifically tries to evaluate whether or not there is any existing coronary disease when you see an initial STEMI and it goes away. Steve Smith at Hennepin did do a study looking at the predictive value of single early post-resuscitation 12 leads with marked metabolic derangement, and they found that even in the setting of significant acidosis and shock and electrolyte derangements, there's still some diagnostic accuracy of an initial 12 leads suggestive of coronary occlusion, but we don't have any data on trending those.
Gotcha. And I'm going to go to Dr. Pepe first. But I do see that Dr. West, since you're Ben, sorry to announce your name earlier. I didn't know you were here. Thank you for joining. Let's go to Paul, then Tom, and then Ben. Go ahead, Paul.
As usual, great stuff. One of the things I was going to ask you, because there's a reason you'll see, I'll explain in a second, is did you look at later if there were heart muscle damage, I guess, indicated by troponins or whatever in any of these cases? Did you do follow-ups or correlate those? Probably troponins may be a little bit more sensitive than when on the old days when we used to have, they weren't even called CKs, they were CPKs in the past, and I'll explain why. Tell us a little bit about that. Did you think about it? Did you actually do it? And was it worthless?
Yeah, that's a great question. We did not in this data set have the troponins readily on hand. I think that's a challenging thing because you would certainly expect to see a lot of troponin elevation in the context of the global insults from a cardiac arrest.
Right.
That would be interesting to see whether that correlates with changes in your ischemic classification on the EKG. We don't have that data here.
And the reason why I was saying that is that back in the old days when I was in Seattle and later in Houston, we actually were tracking that. And we found out almost near half of the cases in the VF subcategory, right, in the ventricular group, didn't have heart muscle damage. And what Dr. Cobb and the other cardiologists were speculating was that we were hitting just the ischemia, or it could be just a small little area that hit the electrical system and caused it to short circuit. So if we got to them quickly, and your data is the strongest thing here, is the issue of how fast you get to them. And so if we got to them quick, had good bystander CPR, got them defibrillated quickly, we actually didn't have any heart muscle damage indication from the enzymes. That's why I was asking about that. So just an interesting point. Yeah. One more thing I would do, and then Tom will know this because I'm so picky as an editor, in terms of language, is that I would not continue to call these STEMIs because they may not be STEMIs, okay, meaning myocardial infarction, but a STEMI pattern might be a nice word to use. That's all. So that, does the pattern resolve, et cetera? Just being my picky self, right, Tom? So, but great work, by the way. This is cool stuff. Good data. And you're right, it has major implications. So
Thanks, Paul. Let's go to Dr. Afterheidi.
I don't have anything additional to add to Chris's superb presentation. It was awesome.
Yeah.
All right. Well, we have lots of questions, so let me go to Dr. Weston, and then I'm going to go to Tanner. Ben, go ahead. Any comments?
Thanks, Peter, and awesome job, Chris. I don't have anything to add. I think Chris did a fantastic job. I'm glad he's where I trained at Hennepin. We're lending him to Hennepin for 3 years, and then we're going to start trying to drag him back to Milwaukee. But really nice job, Chris.
Excellent. All right, so let's go to our resident scientist, my co-host Tanner Smead. I know you have great interest in this topic. Fire away.
Yeah, first of all, I'll echo everyone else. Chris, wonderful presentation. It's a joy to meet more young investigators who are interested in cardiac arrest research. So really, really fantastic job. But so post-resuscitation care is an interest of mine. And when we're discussing bundles of post-resuscitation care, the timing of the ECG, when we should be doing this post-resuscitation, is always a topic of interest. So this paper really caught my eye. I'll say that you really have answered a lot of the questions that I had for you up front. So what are clinical implications for providers in the field? Are there any systems implications, right? Should we be making any changes? And then interpreting this kind of in the context of the OMI paradigm. You covered all those things. So instead, I'll ask you a couple methods questions, one of which was kind of brought up in the chat. So for the classification of ischemic ECGs outside the context of STEMI, did that include like what we would consider STEMI equivalents today, like the De Winter T waves, Wellens, those sorts of things? Or was that just, maybe a global picture of ischemia with like ST depression, et cetera? And then also, you spoke about how the patients who had resolved STEMIs, there was a much longer gap between the out-of-hospital ECG acquisition and in-hospital acquisition. And one of the things that kind of came to my mind that might contribute to that disparity was, if EMS clinicians walk into the emergency department and they hand a very convincing tombstone ECG to the physician, and then that physician, maybe, proceeds to thrombolysis or anticoagulates the patient, which facilitates reperfusion of the culprit artery, and then acquires an ECG, 30 minutes after some of this therapy has been applied, maybe that contributes to some of the disparity in times between those initial ECG acquisitions and the late ECG acquisitions where the STEMI has resolved. So maybe, do you have any comments about, were there any therapies delivered in the ED that could facilitate reperfusion and maybe lead to that late ED ECG acquisition in that group?
Yeah, that's a great question. In terms of the role of thrombolytics in this patient population, that was not something that we noted in our data set and collected as a variable. I think Dr. Afterheidi could speak more to clinical practice at this shop during the time of this study in terms of how much thrombolytics were actually being employed by clinicians. That's certainly one possibility. There were very significant variations in the length of the ED course for some of these patients that we saw, particularly in the resolution group.
Yeah, and then I know, this seems like an urban center. There's probably not a lot of thrombolytics being given compared to like in West Virginia, where I am. There's a lot of rural shops that are doing that.
I would guess probably 0 of these patients got thrombolytics if I had to wager it.
Okay, excellent question. And Tanner, was there a first question there, Tanner?
So for the STEMI versus ischemic versus non-ischemic, were STEMI equivalents lumped into that?
Oh, yes.
Ischemia group? Yeah.
Effectively, yeah, because at this time, the AHA criteria didn't necessarily recognize De Winter's or a lot of these equivalents, which now exist with left bundle branch block and things like that. So those would have likely been lumped into the ischemic. I think that reapproaching this kind of study using more expansive EKG diagnostic criteria, such as OMI, things in the realm of the Queen of Hearts algorithm, things like that, would really be an informative study because perhaps some of these patients still had OMI diagnostic criteria, even though their STEMI criteria go away? And that's something I'm really curious to answer.
Excellent. Great answer. Dr. Shepke, our Deputy Secretary of Health, State of Florida, and EMS Medical Director. Ken, what do you got?
Thanks. I got two things. I want to make sure I understood it right. You had a slide on epinephrine there, and the way it looked to me, it looked like epinephrine was actually causing harm because those people more likely to have sustained STEMI. Did I read that correctly?
That is correct. Yes.
We stopped using epinephrine for shockable rhythms years ago for multiple physiological reasons. I think you just pointed out yet another reason why you should stay away from it. The second thing is, when there's a lack of science on what to do, I kind of just use the common sense thing. And when you were talking about should we wake up our colleagues, I'll tell you, if I'm a person who had a shockable rhythm cardiac arrest, the odds are I'm dealing with coronary artery disease. I'd rather you wake up that cardiologist, unless there is some, especially if it showed ST elevation, even if it was transient. To me, that tells you there's some underlying pathology, most likely. And even after global ischemia, I think it would be to the patient's benefit to get in there, even if the thrombus, because obviously there's always this sort of yin yang of the thrombus growing and shrinking and the normal physiological mechanisms. Just the fact that the SD went down does not mean you don't have underlying coronary artery disease. And I'd be a fan of sending those shockable rhythms to the cath lab, especially if the history suggests that this was an ischemic event, such as they were exercising, et cetera, at the time they went down.
Mm-hmm. Yeah, and I think that clinical context is really key here. It's an interesting conversation in terms of the epinephrine dosing here. Is this really just kind of like a confounder with the duration of resuscitation, and it just happens to be that the patients who are worked longer, according with ACLS algorithms, are getting a higher epi dose? Or is it actually that we're seeing with greater administration of epinephrine, you're causing more myocardial hypoperfusion, more coronary vasoconstriction, harming our patients? I don't think that answer is clear from this.
I would suggest it's going to turn out to be the second.
Yeah.
Mm-hmm. Well, Ken, if it means anything, I side with you on that one, on both accounts. And I think it would be a tough, in other words, how would that end up in, I hate to do this, but the medical legal aspect, someone throws down a tombstone EKG to a jury and says, this is a standard of care, why didn't you take them? I think it's going to be a tough one to say, oh, well, because it resolved. As someone who's done medical expert for a long time, I would wonder how that would go down. Let's go to Dr. Ingram. Charlie.
Yeah, completely agree. I think the epi data is super interesting. And like you kind of phrased it, like my suspicion is it's a signal of something. Also going back to the like time between EKG, my suspicion actually is probably the opposite of yours. I think that there's probably a longer time to EKG for these resolved STEMIs, with the idea that I wonder what the last EKG from EMS shows, right? So was that initial EKG that looked terrible, and then it resolved en route, and then the one that they're handing over as the most recent EKG doesn't look super scary, and so an EKG in-house becomes less of a priority than X, Y, and Z. That's my suspicion, right? I think we, in general, do a poor job of probably anticoagulating our post-ROSC patients quickly, because most of my post-ROSC patients aren't going to swallow or chew their orange aspirins. And so it makes me wonder, like, is there really any actual difference there? Or is it just that we didn't get the last EKG as part of this kind of captured in the study because we used the most ischemic EKG in the study? So I don't know. I think it's completely thought-provoking from a lot of different aspects, and great work. And if you change your mind about going back to Milwaukee, we're down in Florida and it's nice here all year round, just so you know, buddy.
That's right. Spoken as our new Associate Fellowship Director. We have a new EMS Fellowship, so Florida is waiting. Let's go to some of the questions in the chat. Andrew, I think your question was answered. Jeff, Dr. Panazzo, you want to unmute and ask your question live?
Wow. Hey, thanks, Peter. How are you guys doing?
Great.
I just mentioned the recommendation was, Chris, sort of not to get so soon of a 12-lead ECG. But for me, in my practice in the emergency department as well as in pre-hospital, I think it's important to get that 12-lead early to recognize other patterns like prolonged QT. Tanner also mentioned a couple, Brugada and so on. So I think that early 12-lead EKG gives you more than what I like to call ST segment elevation or no ST segment elevation. I don't teach the term STEMI directly. And yes, I wake those cardiologists up. If I'm up and if we're up, they're up too.
They're
Yeah.
getting paid either way. Go ahead, Chris.
I think that's a great point because certainly there's non-ischemic causes of cardiac arrest that we need to identify and quickly recognize in order to guide our management. So, looking at ischemia in the context of resuscitated arrest, maybe that's where that role for serial 12 leads really comes in, encouraging EMS crews to be getting repeat EKGs, see how that is dynamically changing or not in the duration of their care, especially if you have lengthier transport times and are going to be with that patient for a while. But I think that's a great point.
And I think, the other comment, and for me, I have patients who stick in my head, and it seems like a constant argument with the cardiologists down here in this region who do not take the patient to the cath lab, even when it's very clear that they should. It's because they're trying not to have a death on their watch, if you will, right? And there was a patient that we had who they didn't take him to the cath lab until day 3 when he started to have purposeful movements. And when we had a reunion at the firehouse and the wife told me that, I went back to the cardiologist and he said, yeah, even though I knew we should have taken this guy, we didn't take him till later because any death is a knock on me. And so this kind of, in a sense, I don't want it to give them more ammunition to not wake them up. And I agree with everyone else who is saying here that these patients, like, in other words, so I guess my question would be to you, what is the downside to cathing these patients? Patient who had a STEMI, it resolved, you call cardiology. What's the downside?
Yeah, I mean, certainly there's risk of iatrogenic harms from angiography, which I think in the context of a resuscitated cardiac arrest, the risks are well outweighed by the perceivable benefits. If this is someone we're talking about moderate risk chest pain, do they need a cath? That's very different than these patients who are extremely sick, who would definitely benefit from that. I don't see a lot of downsides. And coming from Milwaukee, our academic shop there were a lot of issues with persuading interventionalists to take people, largely to your point, citing concerns about mortality statistics and things like that. Conversely, the Twin Cities is extremely aggressive with reperfusion, certainly the University of Minnesota, but also HCMC, where I'm at now, and a lot of the other shops in the Twin Cities, their cardiologists really are willing to take patients to cath. Which I think certainly lends itself well to studying this further in that context compared to in Milwaukee, where that is more of a challenge culturally.
Good. Okay, great answer. Let's go back to Dr. Shepke.
I really need to leave, but you just brought up a topic I just got to talk about, which is the unintended consequences of bureaucracy. And so 2 things, Peter. You're absolutely right. I think there's a pressure on the cardiologists not to take these because of the mortality during cath lab statistics. And if somebody knows who's collecting that data, let me know, and I'll be happy to reach out and talk to them about how they need to change the parameters. They need to have a rule out for this. This should not be considered a STEMI cath lab. This should be considered ongoing emergent cardiac arrest resuscitation. And those cases are 10 times more likely to die on the table, which is why our cardiology colleagues are a little reluctant, because it does ding their personal stats. Yet it's the right thing to do for the patient. So we have a conflict between the bureaucratic CQI method and what's reported as far as stats and what the patient is in the patient's best interest. So if anybody knows where this is coming from, who's collecting that stats and what the criteria is, please let me know so I can reach out to them and have them fix this issue for us.
Great. I completely 1,000% agree. And what I've learned, it's interesting, Ken, is that even if the patient dies 5 days later, they still get dinged for that death. So I don't know who the hell's making those rules. Doesn't make any sense. All right. Well, Chris, I always give our speakers and our guests the last word. You really provoked quite a bit of discussion here. We had a large audience today. Give us your last word. Give us any further insight. We're excited the fact that you're going to be continuing research in this area. It's clear that there's some unanswered questions. So take us away.
Yeah, I think that ultimately, as EMS leaders, really guiding pre-hospital care for cardiac arrest patients, we really owe it to our patients to aggressively advocate for getting them the in-hospital care we need. And I think EMS is able to leverage a lot of diagnostic momentum towards that initiative. And if we can position ourselves to get EKGs repeatedly and really provide that evidence to our in-hospital colleagues to inform their care, I think that that's great advocacy. It's great patient care, and we can try and advance the field. Emergency medicine really seems to be the ones championing, really taking the EKG to the next level to look at occlusive coronary disease. And it's really trying to get our cardiology colleagues to buy into that and recognize the value in getting our patients reperfused in the setting of their arrests. So I think that that's an area that I'm really strongly motivated to keep working towards in my career, and looking forward to seeing what we're able to accomplish for our patients.
Well, listen, you had a great history. You've started as a firefighter EMT, got an MPH, got your MD, you're in residency, you're going to be coming to Florida for your fellowship. This is amazing stuff. Before we go, let's go to our chief, Lou Steinberg. Lou, what do you got before we go?
Hey, just three things, and some of them were discussed. So I've taught for years that it's the second 12 lead after ROSC that's going to be more accurate than the first. That you need to get the first for all the reasons you all mentioned, but the second one is going to be more accurate. But that relates to something I used to teach of a patient who had a normal 12 lead, had an obvious STEMI in the parking lot of the ED, and a normal EKG in the ED, wound up going right to the cath lab with a major thrombus that got sucked out. So the fact that it was there doesn't mean, which gets into something we talked about, that we don't know how many of these patients actually had significant blockages afterwards. I think that's an important thing that needs to be associated with this. Mm-hmm. And the last point, epinephrine up front aside, in the VFib arrest, you also included norepinephrine and epi drips, which came first, the chicken or the rooster? You know, how many prolonged STEMIs needed the pressors to raise their blood pressure adequately versus how much of the pressors caused the prolonged STEMI. So really it's an association, but it's not a cause and effect. So those are my 3 points. Thanks.
Well said. Well said. Excellent. Great discussion, guys. The link to get to Dr. Pepe's webinar is right there in the chat. Chris, great discussion, great presentation. I'll have this up on YouTube today. You're always welcome back. Every Friday we do it at 11 o'clock, and I'd love to see you here again.
Wonderful. Thank you so much, everybody. I appreciate your time.
All right. Take care, everybody.